Good afternoon, everyone, and we are going to start the finals of Think Under the Apple Tree session, and we have 10 finalists here, and our judges are also there on the dais. So let me tell you that judges will be judging depending on novelty of the presentation and practical application, social or clinical impact, cost efficacy, potential commercial viability of the product or whatever they are showcasing. So total 100 marks are there, 20 marks for each category. So all the best to all the innovative minds here. So let's start with the first presenter. So you'll get 4 minutes of presentation and 2 minutes for question and answer from judges. So first we have Dr. Neha Dholakia, who will be presenting a novel ultrasonic intraocular lens cutting tip and IOL holding forceps. Dr. Neha Dholakia. Timer for 4 minutes. मैं बुला लेता हूँ अभी ना, I'll call them.
Are tedious and traumatic to the wound and the endothelium. The snare technique, which cuts the IOL into two halves, the twist and out technique, which requires a swift and skilled surgeon and can stretch the incision if not performed properly. IOL explantation through a cartridge, which needs force and can stretch the wound out. Crocodile scissors, which are bulky and cause rocking of the IOL and endothelial damage, and thereby getting post-operative striate keratitis and even a Descemet's detachment at some time. Introducing this innovative tip, which makes it easy for any surgeon to cut the IOL extremely easily into 3 or even 4 or even 5 parts. Each sliver is only 2 mm in width and hence can be removed easily and gently through a 2.2 mm incision without stretching the wound or extending the wound at all. The reasons for explantation are broken haptics at the time of insertion of the IOL, an unhappy patient due to halos and glare, especially in ringed IOLs, refractive surprises, dislocation or subluxation of the IOL. Now the tip is a stainless steel tip which is designed after many attempts to get the length, breadth, angle and sharpness right. The phaco probe has to be primed just as usual with the normal tip, and then the tip is removed and the IOL cutting tip is screwed in and tightened, and then over it the sleeve has to be attached. The forceps are such that the jaws of the forceps open and close vertically just like the mouth of a crocodile, but the grip is such that it is horizontal and open and close parallel to the ground between the thumb and the middle or the index finger. It is ergonomically designed for ease of use. The surgeon introduces the forceps through the side port and gets a good bite of the IOL. Then the surgeon positions the tip and simply presses on the foot pedal. The vacuum and aspiration are at 0, irrigation is on but low, power is between 20 to 50, that allows us to cut any hydrophobic or hydrophilic IOL with ease. As you can see here, the IOL is cut just like butter, so easily within 1 second. And the pieces can then be removed through the incision without extending the wound. This is an in vivo demonstration of the same. The IOL is being cut into slivers of 2 mm each, and each sliver can be removed without stretching the wound. The pieces have to be aligned parallel to the incision such that each piece can be removed efficiently without damaging any part of the eye. Advantages over the other techniques: can easily explant the IOL without extending the wound at all. There is no tilting of the IOL like with the scissors. There is no stretching of the wound. No special surgeon skills required. One can cut the IOL into even thinner slivers if the need be. All in all, this technique uses the ultrasonic power of the phaco machine and removes the IOL, respecting the posterior capsule, the wound, and most importantly, the endothelium. Thank you very much.
Judges?
Any questions?
Yeah, I think it's a very innovative design. My question is, with which phaco handpiece was this prototype designed to fit into?
Nidec.
Okay, so can it be extended to any
Yes,
handpiece?
yes, yes.
Because the dimensions may
Yeah,
not
so
suit.
we have around 6 tips.
Okay.
One for the Alcon Infinity
Compatible
Century,
for
yes,
different
one for
patients.
Johnson Johnson, one for Oertli, one like that.
Okay, and what is the approximate cost?
13,500 for the tip and the forceps,
Okay, and for how many uses does it last?
like a phaco tip.
Okay,
100. I have cut around 50 with my tip.
okay,
Just
with a single tip.
doing all the experimentation.
Okay,
Yeah.
okay, that's
Okay.
good.
Thank you.
And you have claimed many advantages.
Yes.
So it is just the perception about those advantages, or have you done any study to prove that this is that, like endothelial cell loss? You said there is no endothelial cell loss.
No, 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 no.
So
it is
so
less
so no no. So
endothelial.
let me finish my question.
Hmm.
So have you done any study to prove?
No.
Okay.
But luckily, it's available commercially on iolcutter.in. So every second day, I have somebody calling me, texting me. So I have a lot of videos of Dr. Kamal Kapoor and Dr. Santosh Purti and Ashish Vaidya, all these people who have done the surgery, Dr. Samresh, who've done it, and next day patient has been 6-6 chaka chak.
No, no, that is okay. That is okay. That is
Yeah. But yes,
six,
come to
chaka
like
chak,
that,
pristine, clear is
Correct,
all
correct.
are terms used by the
Yes,
novice.
Yes.
Means
correct.
I'm not telling they are novice. They are all experts.
Yes, yes.
But in the era of evidence-based medicine,
I
we
understand.
need some evidence. So I'm
Correct.
suggesting that you should
I'll
create.
do it,
This
I'll
is a
do
very good idea
I
that you
will
have
do it.
produced. So definitely, I'm
100
giving idea that now
Yes. Or
produce
I'll
some
have to tell
evidence.
everybody who's using it, to request is to, if you can do a cell count before and after, because I don't get so many cases of removing IOLs. So, yeah, so the tip is titanium and the forceps I made of steel because the titanium ones will break. So, we have the retinal forceps or anything, don't try to use those because we have to give very good counter pressure. So, in that I broke one or two also in vitro. Then with the steel one, the jaws open and close like this, they are serrated and the grip is horizontal. So, you don't have to hold it like that through the side port. This one
So
works
what
very
was
well.
the most common complication which you faced?
Broken haptic at the time of insertion.
No, while taking it out. So with this instrument,
Which is the common complication. So I would say sometime like you have to be very slow, and if you have not it's not controlled, then at least when you're coming towards, so we have to go with the tape halfway up to the center of the pupil. That time I'm moving my right hand forward, and after that I move my left hand backward.
Okay,
So that we stay in the center. So if somebody just thinks I have to go like this, you can end up
Chances
touching.
of.
Yes, yes. And also right at the end when the IOL is getting cut and the power is good, it can just like move away that piece.
so what was the power which you used?
In 20-30 power we can. So aspiration is 0, irrigation is on, vacuum is 0, power between 20 and 30.
Good innovation.
Thank you, sir.
Thank you, Dr. Neha. Now I call upon Dr. Anamika Paul. Yeah.
Good afternoon, everyone. I'm Dr. Anamika Paul, and today I'll be taking you to a journey of Perkins applanation and how we can use it in an ergonomic way. So, IOP is a very important risk factor in glaucoma, and its measurement is very important. Evolution has been taking place in IOP measurement. First, it started with digital palpation, then came Chiot's tonometer, and then came the gold standard, Goldman applanation tonometry. Now, Modern development is still continuing. We have Pascals, we have rebound tonometry, we have NCT, ORA. But the problem comes when a OPD is very crowded with the increasing number of glaucoma patients. We need a fast, accurate, and convenient tool. Eye care and NCT, no doubt, they are very good screening tool. But we need something, but its utility in accuracy and management of glaucoma is questionable. So we need a handheld device which is user-friendly, portable, accurate, reusable, and cost-effective. So here comes Perkins applanation tonometry, whose results are comparable with Goldman applanation tonometry, and the good thing about it is it can be used in operation theatre because it is not slit lamp mounted. Now the problem with Perkins is, since we have seen in the COVID times, we have to bend a lot and be in close proximity with the patient, which will lead to airborne infection, and doing this the whole time in OPD will lead to backache. So just think about the situation where we are doing it every day. The clinician will land up with health problems as well as it will reduce the productivity. Now we propose an idea where the camera is attached to the Perkins and we are enabling the real-time visualization on a screen. Thus, we eliminate the bending as well as lowering the airborne infection. This is the camera, which is actually HD camera, and it is connected via Bluetooth and Wi-Fi. It is lightweight, small and compact, and it is cost effective, just one-time purchase of ₹700. This camera will fit behind the biprism of the Perkins with the help of 2 rubber bands. So we have divided it into 2 steps. First step, we attach the camera with the Perkins tonometer with the help of rubber band, as shown in the video. And in the second step, we connect the camera with the screen. First, we download the HD Wi-Fi CamPro app, and we connect it with the help of Bluetooth or Wi-Fi. This is how it works. We stand straight, place the Perkins prism very gently over the eye. My eyes, as you can see, it is on the screen, and we can beautifully see the Myers. It's easy to learn. The sisters or the optometrists in our hospitals are also doing this when the OPD is very busy. We are doing this on a general basis right now. So it is why I'm saying it's cost effective is each tip of the eye care will cost 100 rupees. We technically should replace it after every patient, and the camera is one-time purchase and it costs only 700 rupees, and the rubber band hardly costs 2 rupees. To summarize here, it's actually a faster, accurate, and cost-effective and user-friendly thing. Since both the camera and Perkins are portable and rechargeable device, so maintenance becomes simplified. It enables use in the operation theatre, and it can also be used in teleophthalmology. I'm saying in operation theatre, like when we are doing examination under anesthesia for pediatric patient, we are using it. We can see the Myers on the screen when connected to the TV. So the entire surgical team can see the screening process, and it has a short learning curve, so teaching and learning becomes easy. I would like to end here by saying all things are difficult before they are easy. Thank you.
Interesting. Thanks. Why did you thought about this idea? How did it came to your mind?
So actually, me and my ma'am were discussing one day when COVID had come. We had to purchase, our institute had to purchase around 6 eye care devices. And eye care as it is, it's costly. And we can use it for screening, but for management of glaucoma, it's really questionable. So we thought of an idea. And really, while the glaucoma, it's like increasing day by day since the awareness is increasing. In a busy OPD, we can at least reduce the load by first doing the AT, and later on we can see the disc and all in the slit lamp. At least the AT part can be reduced in the screening part as well.
No, but thinking about putting a camera and all, is there someone has done this kind of work in?
I don't think so, sir.
Because this is really innovative. Where do you think, where else you can apply this same technique in the handheld settings? You think somewhere else you can apply besides tonometry?
Tonometry, sir, many people have used those fundus camera, like mobile fundus camera. Actually, I had some idea from there only, like mobile-based fundus camera.
Very interesting. Can you use it in handheld slit lamp maybe to check the corneas?
Handheld slit lamp also.
Very interesting.
From where did you get the camera?
Sir, actually we were thinking of using a mobile on the Perkins. We tried attaching it, but it was becoming very very like heavy. Then I searched Amazon and all the products where we can get. So finally I ordered this, and I had replaced many other cameras also. Like
Because
some
you need
cameras
to
were
see
not
the
fitting.
focal length also,
Sir?
mix and match focal length.
Yes, sir.
You have to do that.
Yes, sir. So finally we attached it, and finally after many negativities and positivities which came in the way, finally we selected this one. It's very lightweight. It does not add any weight when we add over the Perkins. And after that, to see whether the AT is accurate or not, we first check the applanation in another room, and we did not tell the result. We did not disclose the result. Then we asked someone else to check the AT of the same patient. It was almost approximately same. So then we started using this. We mounted it on the Perkins, and we are using this after steriling after each use.
My only worry is about your fixing of camera with rubber band.
So we
Because
are
that rubber band is most likely touching your prism also.
Sir,
It slips towards that.
yes, sir. We had a problem regarding this. So what we are thinking is, like, we have started already. We are thinking about the silicone tube. Like, I had an idea from a retina person. She told we can do something from the band buckle which we are using. We can use it through the from there.
Yeah, I really liked your idea, Anamika.
Thank you,
But
ma'am.
two issues. Is there a learning curve because the person who's using has to look at the screen and then touch the cornea, so they should not abrade the cornea. That's one issue.
Ma'am, somebody who knows Perkins already, it should not be difficult for them. And initially, like, I was more comfortable with Goldman applanation tonometry. For me, learning Perkins was difficult rather than looking at the screen and doing the Perkins, because one, you just fix it over the eyeball, like
And
over the
then
eye
look at
cornea,
the
and then looking there is not difficult. For me, learning Perkins was, I guess, more difficult.
Okay.
But I learned it.
Yeah,
anyways.
but I
We are
think
doing it.
definitely it may not be technically as easy. And another issue, actually, the Perkins tonometer, in between, they had stopped manufacturing it. So I don't know the long-term use of
using it.
this innovation, because if the product is no longer available, then we don't see its prospect.
Ma'am, for pediatrics, I guess in operation theater, Perkins is the only
Yeah, at
best
present
thing
it's
which we
there,
can
but
use.
they have actually stopped manufacturing. Okay, thank you.
you, ma'am. Thank you.
No, but her, whatever her concern was is right, that when it's touching the cornea and simultaneously you have to see the screen. So that time while you move your gaze from the tip of the Perkins to the screen, probably you might lose the contact or you start pressing hard. So
Sir,
that
there-
way definitely it is some difficulty is there. So probably try to, means of course you have a brilliant mind. So try to sort out this problem, that how to overcome this difficulty also. And also again, as I said to the first speaker, that do some again randomized control and compare
Yes, sir.
and see what is the outcome, means how much is the reliability and reproducibility.
Thank you so much, sir. Thank you so
Sign
much.
a patent and talk to Perkins about modifying their thing. You should talk to them, sign a non-disclosure agreement with them before you do that.
Okay, thank you so much,
Then
sir.
they will definitely increase the cost.
So next we don't have Dr. Ganesh joining us here. So I call Dr. Sonavan Atul Vijay. Please come, sir. After Dr. Sonavan, we have Dr. Prithvi Chandrakant. I think you can be ready in the podium.
Next. This is not my presentation. सोनावणे. Yeah,
You
this.
are also presentation. Please.
Can I start? Make it full screen.
Full screen है इधर में.
Good morning, judges and friends. After years of just thinking over designing a seemingly trivial, but actually significantly important instrument, that is the lid speculum, I finally acted this year to design a new eyelid speculum, which tries to overcome the problems associated with current eyelid speculums. I would like to present a new eyelid speculum design for intraocular surgeries, which provides adequate exposure of the surgical field without causing intraocular pressure rise by pressure on the globe, and also avoids damaging the levator palpebrae superioris. We encounter a few problems during the use of existing eye speculums, including inadequate exposure, especially with the Baraka eye speculum, pain during eyelid retraction when operating under topical anesthesia, and an increase in intraocular pressure in the range of 5 to 10 millimeters of mercury in the case of eyes with a shallow orbit or large eyeball due to pressure on the globe by the speculum. Post-operative ptosis occurs in eyes with a small palpebral fissure due to levator palpebrae superioris damage by the eye speculum. Routinely used eye speculums at present include the Baraka eye speculum, which is lightweight but provides inadequate exposure many times. Liberman's eye speculum, which provides adequate eye exposure but presses on the temporal side of the globe in eyes with shallow orbits or large globes. And Cook's eye speculum, which does not exert pressure on the globe but provides inadequate exposure by retracting only the central part of the lid with its small blade length, while the medial and lateral parts hang sideways, narrowing the surgical field. In a eureka moment, I realized that current eyelid speculums separate both eyelids simultaneously, leading to the issues we face daily. If both the eyelids are retracted separately using two individual superior and inferior eyelid retractors, we can overcome these issues. During routine electric work in the house, I had observed that the copper wire used by electricians is very malleable and can be bent easily into the desired shape. So, I purchased an 18-gauge copper wire from the local electrical shop, and by following these steps, bent the wire into the desired shape and made my first eye speculum for retraction of the individual eyelid. This is the new improvised design, which I am currently using. This is a short video of the speculum in actual use during manual small incision cataract surgery. I am happy. Been able to achieve my goals of adequate field exposure, avoiding intraocular pressure rise, and preventing levator palpebrae superioris damage.
Other than enhanced exposure, are there any other advantages with respect to pressure on the globe or?
Yeah, it doesn't touch the globe, only the eyelid is retracted. So there is no question of any increase in intraocular pressure.
Okay. No, instead of using this speculum, we can just use a stay suture. So, in what way is this beneficial?
You don't have to touch the eyelid. So,
Okay.
it is not traumatic.
Okay. And have you tried using a solid blade, like instead of the wire model?
Yeah, I am planning to do that because it will
To keep
uniformly distribute the pressure and cause less trauma to the lid.
Okay.
That is my next idea.
Can we get next presenter, Dr. Kasturi? Next one.
Dr. Prithvi. After Prithvi, we have Dr. Virangi Doshi. Are you here? Be ready in the
Tactile,
next
a
position.
tactile marker for medications to assist.
Yeah.
Tactile, a tactile marker for medications to assist patients with low vision. Imagine a blind patient who has been prescribed 3 different eye drops. The biggest challenge? Identifying which drop to use and how many times a day. Now consider other scenarios. A patient with blurry vision who cannot read the label, or someone without assistance to help administer the drops. Studies have documented cases of inadvertent use of non-ophthalmic drops, highlighting this as a significant issue. How can we create an affordable, practical solution to help visually impaired patients correctly identify their eye drops and dosage? Our answer to this challenge is Tactile, a simple yet effective tactile marker system. We explored 3 prototypes. Bindi markers, most affordable approach, using Indian bindis, which cost just 10 rupees per set, as tactile markers on eye drop bottles. Embossed label markers, most effective approach. A label embosser, available on Amazon for just 999 rupees. It is used to create raised numeric markers by pressing a lever with the desired alphabet or symbol. The embossed strip is then attached to the eye drop bottle, providing an easy way to identify the correct dosage. 3D printed markers, customizable approach. 3D printing tactile markers and attaching them to eye drop bottles. Different shapes represent different drug categories. A triangle for antibiotics, a plus sign for lubricants, and so on, and it costs 1 rupee for a piece. Evaluating the impact, we conducted a study with 2 groups. Control group, 150 patients, used eye drops traditionally. Intervention group, 150 patients, used eye drops with a tactile marker. The results? Higher adherence rates, hence fewer missed doses. Increased ease of use, making medication management effortless. Greater confidence in self-administration, hence empowering patients to be more independent. Why tactile matters. Enhanced medication identification, reduced medication errors, improved treatment adherence, increased patient independence, minimized adverse effects. It is cost-effective, scalable solution, improved quality of life, reduced cognitive load on patients, enhanced caregiver efficiency, potential for smart healthcare integration. Conclusion, tactile markers for ophthalmic medications enhance patient safety, reduce medication errors, and promote independence among visually impaired individuals. Ultimately, this leads to better treatment adherence, increased confidence, and improved health outcomes.
Yeah, that was a good idea. So you want this to be implemented by the caregivers or the manufacturers or the patient attenders?
So at present,
what is
we are
your
doing-
goal?
Yes, sir. Actually, at present, we are doing it for all our post-operative cases.
So you are doing, as
yeah,
the
we are doing
healthcare
it.
provider,
Yes.
you are doing it.
Yes,
Okay.
ma'am. So the ward nurse, she has this set over there. So she just has to, while explaining itself that you have to put 2 times, she uses this and she presses it 2 times and removes it and puts it over there onto the eye drop, not on the cover. So when they put it the eye drop, it becomes very easy for those patients and the patient attender to actually identify how much drops to put. So that becomes very easy for them. And later on also, what we saw is they came back and they asked us to put this on the next drop also, because it became very easy for them to actually identify how many times they want to put it. So not just that, even if there's no caregiver, the patient actually can touch and feel how many times, and the patient can tell them, see, this is 2 times, so you can put it for 2 times. So most of my retina cases, we started doing this. We have extended it to all our cataract cases also, and it became very easy for us to actually explain and counsel the patient, and their adherence became very, we stopped seeing cases which they used to miss put in each eye. So that becomes very easy for us to actually monitor, and the efficiency also increased. You would like to see?
Yeah, no, this one we know.
taper is we've been using vertical lines. So after each vertical line, if we are taking 4, so 4 vertical line and we put a horizontal line. And then we put 3 horizontal line, 2, 1 like that.
Interesting. Can the patient use it by themselves? The patient, can they use it by themselves?
The patient,
if there is no caregiver.
Yeah, and without caregiver, he can identify how many drops he has to put, but then putting it is that is not.
I'll tell you a story of a patient I was treating, rheumatoid arthritis. His fingers were all thing, and we wanted to operate cataract, but then there was no caregiver for him. So I said, how are you going to put the eye drops post-operation? He said, he give me 2 weeks. After 2 weeks, he came back. He was a 70-year-old gentleman. In Singapore, they use chopsticks to eat food. So he came with a chopstick with a rubber band tied on it, and he used the chopstick, and using the chopstick, he was pressing on the bottle to put the eye drops. So that's one of the most innovative most innovative invention I've seen by a patient himself.
Yes,
and he was like a very simple person, but I'm just thought of sharing the story.
Yes, when you told the rubber band, actually, what happened? One of my patient who was blind from childhood, so she came after I made this. She came and I asked her, how do you identify which? So they like, I put 1 rubber band on the eye drop. So what if you have 2? So they're like, I have 2 rubber bands. Then like, what if you have 3 medications? Because her husband is also blind. So then she like, I keep these 2 medications in one room and the other 2 medications in the other room. So then I started using tactile. I started giving her tactile, and she came back. She's asking, you put the same thing again, because now I can keep all the drops in the same room, and it becomes so much easier for them to actually put it. So that is the kind of impact we are having with this.
No, but with the patients with poor vision, the problem is, one is of course the recognition of the drops, and the second is that how to put it themselves, because that is the separate issue. So
that is a separate issue.
So this, yeah.
Thank you.
Thank you, Dr. Prithvi. Next, we have Dr. Virangi Doshi, ROP sets. After Virangi, we have Professor Gopal Pillai. So, sir, you be ready on this side.
Presentation.
कौन सा सेशन था आपका?
सुनिए, सर को भी अरेंज करिए. इसके बाद डॉक्टर गोपाल पिल्लाई.
Start. Hello everyone, I'm Dr. Virangi Doshi and I shall be presenting to you our unique do-it-yourself model of ROP Shankara Skill Transfer System. Don't we all remember how scary the idea of screening these tiny souls felt at first? Well, it's an even trickier situation when we have to examine and screen and click good quality images using the wide fundus cameras, which require a good hand-eye-leg coordination, which if not competent with can put an undue stress on the child. As we know that an important part of screening is documenting, which is done with wide-angle cameras, which involve a probe resting on the eye in one hand, a foot pedal being used with the leg to click good images in a jiffy, and the eyes and mind dynamically taking note of all of this. To ace this sync needs practice, and for practice, we need simulators. That's when we put our Jugadu minds at work and devised our ROP Shankara skill transfer system using a newborn baby mannequin available online and a commercially available RETI, and thus saved us a huge cost. To make this model, what we did was we cut the rims of the eye of the mannequin baby for a better exposure, and then secured the RETI from underneath using a hot glue. Print out templates of various ROP pathologies can be molded and used as templates and placed in the posterior detachable portion of the retinae, as shown in the video here. Alternatively, for a good high definition image, we tried using the phone screen as a template, as shown here. To study the effectiveness of this study, we conducted a small in-house experiment with optometrists who were not trained in ROP screening photography, and we observed that the time taken to handle the machine and to take good quality images reduced over time. In contrast to other simulators who burn a hole in the pocket, can be used only for direct or indirect ophthalmology simulation and are only used for specific pathologies like diabetic retinopathy. Our unique model is not only cost effective, can be used either for direct and indirect ophthalmoscopy simulation, and multiple pathologies can be used. To the best of our knowledge, there is no such model available for ROP photograph training. Wide-angle photographs are not possible due to certain design-related issues in our model. This aspect is under consideration. Thank you all for your patient listening.
Yeah, I think the use of simulator goes a long way in training the technicians with the handheld camera, and it is the need of the hour as we see more children being affected with ROP.
We also noticed that the optometrists which we were training, and they were also more comfortable when they were going for ROP community screenings. So we
Can
have
the
a couple
same
of
technique be used to train the postgraduates to screen with
Yes.
indirect ophthalmoscopy?
Yes, that's
for
what we
ROP?
have also been doing. Like for indirect ophthalmoscopy, also this is a good idea.
Okay.
And even for just a screening, like when we first screen for an ROP child, we are not really comfortable with that working distance and all. So using this model, I myself felt that it was better when I actually tried screening the child for the first time.
The size of that reti, isn't it big for that mannequin?
So basically that mannequin, the head of that mannequin is hollow. So just the only challenge was to get the eye inside. So for that we just had to make a cut on the head of the mannequin, maybe L kind of a cut, so that we get a better opening, and then we could insert that eye from the inside.
Very interesting. And I think I should borrow your presentation for my talk other day, which will be on smart class in ophthalmology. Just one curiosity, and probably something for you to think about is you've kind of trying to simulate as many things as possible. But one of the things also seen in babies, they might be moving, crying, and all those things, which might be. Have you thought something about it to make it little bit more?
There were two aspects to it which we were thinking. One is that initially, while the process of using that machine itself, like the RedCam or the Forest which we used in our case, that handling of the foot pedal and holding the head and the probe in one hand, which is also heavy, was also tricky. So that part the optometrists and the trainees, including the fellows and DNBs, are comfortable with. So that aspect gets clear. The second part of which you're saying that the eyes will be moving and all, what we thought of initially was that we can attach a spring inside. Rather than sticking with the hot glue gun, we can attach a spring inside so that eye is kind of having some motion, but that is what we're under trial. Yeah. Thank you. Thank you.
Next we have Professor Pillai. After him we have Dr. Raju S. Are you here? Dr. Raju, be ready on the other side.
Thank you very much, ma'am. And this is a point of care test kit to identify non-responders to anti-VEGF. So it's from the proteomics and molecular medicine study group that we have. Our mentor is always of opinion that if you have innovations, it will touch 1 billion eyes. So good tight metabolic control, laser, anti-VEGF and steroids, vitreous surgery, these are the mainstay of our treatments. So anti-VEGF is the mainstay of treatment in diabetic macular edema. And there are patients who do really well, like this patient, with significant improvement. But there are about 30% of patients, despite multiple anti-VEGF injections, they are non-responders. It's about 30% of the whole population which are non-responders. How to differentiate between responders versus non-responders? Only after 5 or 6 injections will you come to know whether somebody is responding or not responding. So we are trying to find out in the first injection itself whether it is possible. So first of all, we have to take the aqueous and store it at minus 70 degrees. And then first thing that we looked at was whether VEGF was very, very high in the non-responders. And we looked at that through ELISA. And we found out that 3 levels of VEGF were there. One group of VEGF was there which was very, very high, 2500, which behaved completely differently from the others. But this was a very, very small number, about 3 to 4%. So we looked at other reasons. So we defined responders and non-responders. Responders were defined as macular thickness normalized in 6 months, or reduced more than 40% in 3 months, or only if 4 injections were required in 6 months. And more than that, in any of the 3 criteria, would be a non-responder. So we looked at VEGF as well as a lot of other things. So when we looked at VEGF, we understood one very important thing. The non-responders VEGF was lower than the responders, because the number of injections that we took for non-responders would be much higher, and their VEGF levels finally would be lower. And the non-response, so we understood, is not because of VEGF. It is not mediated through VEGF, but some other things. And so we looked at the other things, like the protein. These are the proteomic differences based on 2D gel electroscopy to differentiate the non-responders from the responders. We have 5 different proteins which are different. And then we also looked at flow cytometry bead analysis to look at cytokines. We looked at about 12 cytokines, and we found out that IL-6, IL-8, MCP1, and IP-10 were far higher in non-responders than in responders. So that was published. And we also looked at OCT parameters, because OCT is finally the imaging, the non-invasive, and the type of edema, hard exudates, ISOS junction. We found out that IL-6 levels were higher in spongy, disrupted ISOS junction, and if there is drill, like that, in each of these we found out that. And the next thing that we are looking at is to find out a lateral flow kit, just like a pregnancy kit or something like that, where we are introducing the aqueous when we are taking the first injection, and that drop of aqueous we will put on the sample pad. It will go into the conjugate pad where all the chemical reactions take place. We have proteins and colorimetric proteins which are conjugated there, so that if that protein is present, then the color will change. And also the cytokine. So we have 2 test kits which are developed. One is a protein test kit, and one is a cytokine test kit based on the non-responsiveness of the patient to anti-VEGF agents. And here is one patient in whom subfoveal detachment, OCT 600 microns, in which this patient was positive for proteins. And this is again another patient in whom it is positive for cytokines, multiple cytokines, IL-8 and MCP1. So validation is the natural next step. Currently, we give multiple anti-VEGFs to decide whether it is responsive, non-responsive, and then decide on steroids. Now, the combination of protein and cytokine lateral flow assays can help us pick up the inflammatory cases, and we can take a decision within 10 to 15 minutes. Once validated, it can revolutionize the case of DME. Thank you very much.
So, a very interesting study, and because I do a lot of omics, so I'm just thinking, how many patients you have done to come to an analysis that this is the proteomics and these are the cytokines and these are the responder, non-responder, and have you validated and published that study before coming to
We did about 80 patients, and what we did was we did not cut down in the center. We looked at the extremes, extremely good responder and the extremely good non-responder. And then we took cytokine samples from those, from aqueous, and then we studied it.
Yeah.
So this is a proof of concept, and now we need to validate it.
So for me, I will have concerns for the proof of concept with the 80 patients, because there are so much of heterogeneity in the patients which we see, in the proteomics which we do, in the cytokines which we do. So it will be good if it comes up, but first of all, the proof of concept has to be really done on a very robust study. I will probably relook into that proof of concept again. So that's my point.
In this, you said that only the 2 extremes you study and
Yeah,
you took it.
the 20 patients from either side, sir.
Sorry?
20 patients, 20 the best responders
20
and 20 of the worst responders. So that, we are not cutting in between.
No, so then this has basically given you the hypothesis. So now with this, you have to prove in the general, entire population rather than just the 2 extremes.
Yes, we need to validate in a multicentric study. That is a natural next step. We are asking funding for that from the government, sir.
it's a good idea that we can prevent unnecessary injections in these patients who do not respond to anti-VEGF. But my question would be, what next? So once you know that they are non-responders,
we can go to cytokine inhibitors, steroids, Ozurdex. Those things are the, for when anti-VEGF is not effective, we can move to alternate therapies. Currently, we move to such alternate therapies after 5 or 6 injections.
okay, so you can
Yeah, we can very early decide on which drug to use, etc.
Okay.
And now newer drugs are in the pipeline also, like other cytokine inhibitors, which are currently being used in inflammatory diseases, which can also be tried to be investigationally used in these cases once this comes out.
Okay, and what will be the cost of that card test which you were
Yeah, it depends upon the numbers that we
When it
generate,
comes-
but generally it will cost somewhere around 2,500 to 3,000 rupees.
Okay, thank you.
So conceptually, this is wonderful thought, sir. I think the way forward is to validate those findings and then, but well thought of, sir. It's
So-
surely going to give some kind of light in future management of.
So again, once a proof of concept is there, we have the clinical trial network, we can basically try to validate through that. Thank you.
Okay. Thank you, Dr. Pillai. Now we have Dr. Raju S. And after Dr. Raju S, we have Dr. Chaitanya and Kim. Are you here, Dr. Chaitanya? Yeah, please be ready over here.
Yeah, good afternoon. While cutting costs is an important part of any innovation, being futuristic is also equally important. I am going to present here a futuristic design of an ophthalmoscope or a video indirect ophthalmoscope. We all know that binocularity is achieved artificially by reducing the IPD by using prisms or mirrors in an indirect ophthalmoscope, while the monocular indirect ophthalmoscopy principle is used for imaging using a mobile. The video indirect ophthalmoscope records images or videos in 2D. When we have so many options, why this one and what's different? Well, this invention is completely a digital device with no optics of the indirect ophthalmoscope involved. What are the new possibilities? We'll be able to re-erect the images, and re-inverted images can be seen at the click of a button. Real-time teaching of the students in 3 dimensions. What is as seen by the examiner can be seen by the students, especially helpful when teaching students for ROP. We can record videos of video indirect ophthalmoscope in 3D. Not only this, we may be able to see the images on a wide screen right in front of our eyes. Is it all possible? Yes. How is it done? It is done using a twin camera system with a head-mounted near-eye display. So this is the device concept wherein you have 2 cameras with the light close by, and behind it is actually the near-eye devices, display devices, which are right in front of your eyes. So the right camera image will go to the right eye, and the left camera image will go to the left eye. And if you have 2 cameras which are set at 60 or 65 millimeters apart, then we will be able to do the oculoplasty, squint evaluation, and the pupil examinations using appropriate software. One can digitally overlay scales for measurements, making these examinations accurate, recordable, repeatable, eliminating the subjective errors. As a proof of concept, I invested on these near-eye devices. These were the 2 devices on which I tried. And here I am doing the indirect ophthalmoscopy using this device, and we are able to record the fundus image using this. Here you can see that it's telecast live onto the monitor there, what I'm seeing through my eyes. We have applied a patent for it, and it has been accepted for the novelty. This is how I would like the indirect ophthalmoscope to look in future. The future looks bright with near-eye displays becoming smaller and smaller, and the transmission technologies allowing rapid data transfer with improved camera technologies. This is how the AR glasses are going to be in future. The small form factor, you can shrink the indirect ophthalmoscopy into this device going forward in a few years' time. This is what I would want, and this is the Samsung device, which is likely to come back in future in the next couple of years. So the conclusion, this device, if we are able to make one, can be a device of many possibilities where you can not only see the fundus, do stereoscopic point of view examinations, we'll be able to train our postgraduates better. We can get simultaneous viewing of experts of what the examiner is seeing, and we can do advanced examination solutions for squint and oculoplasty. And laser can also be integrated into the design. Thank you so much.
How much is going to be the cost of this?
So the cost of the device which I got was around 45,000 rupees, and other was 65,000 rupees. Going forward, I feel these devices are going to be mostly into the consumer market, and the prices can be expected to good quality to be around 50,000 rupees. The Apple one is exorbitantly priced at around 3 lakhs, but still going forward, if you can integrate all of them, and even visual fields can also be done. So you can integrate the visual fields into the same near eye device, and all in one device is possible to be done if we all put our heads and minds together.
What I understand is this device helps the retina to be viewed on a larger scale.
Yes, larger screen in front of your eyes. You don't require another screen. So what the other doctor was showing, the applanation tonometer. So you can just connect it via Bluetooth into this device, and you don't have to bend or look anywhere else. It is right in front of your eyes.
But the technique of indirect ophthalmoscopy is going to remain the same.
Is going to remain the same. So you can indent also. And whatever the examiner is seeing, using a Bluetooth or Wi-Fi, it can be seen simultaneously by other students in the room. Or you can telecast it to somewhere else to get the opinions.
So no, so it's going to be, what I understood, that more useful as a teaching tool.
Teaching, if you integrate a visual field, you can do the examination for the visual field for the patient. Visual acuity tests also can be integrated into this. So all things can be done going forward.
What is for examiner?
This is for the examiner, but the other way around, if you put it to the patient also will see the fields. So you can tweak it for the visual fields also and other examinations also.
So what do you think can be the major limitation or the potential side effect of such a device? Anything, this particular device? Any side effect or any potential limitation which will stop it from getting into the market?
I don't think so, because everybody now going forward, you can see Meta, Apple, everybody getting into this.
So if you look into the technologies,
most likely, yes, sir.
Yeah, so if you look into the technologies which have come up with the visual field, so there were few who have come up with this thing. One of the thing is the migraine and the kind of dizziness and the kind of thing you get it after 15 minutes of wearing was really unbearable for a lot of patients who were doing the visual field, and even the thing. So there are at least 3 companies which have shut down because there was this market which was not getting there because of this potential.
Yeah, I'll explain to that. That is because of the near eye disparity. So they need to get the calculations correct, because when you are trying to see far and when you are trying to see near, that now with the devices like Apple, they are able to monitor the eyes and see whether you are looking for far and near, and based on that they're going to adjust your
so that's going to be one of the limitations which you have to kind of make sure that it does not cause, because that can cause.
No, but that's all been overcome now with the new devices. Because they are tracking, there is eye tracking going on in all these devices. No, sir, you are doing the examination. So when you are doing the examination, indirect ophthalmoscopy, you are saying I'm able to see an elevated lesion. But that is not appreciated by your student unless he does it himself. So when you are doing, he'll put on one more device like this, and he'll be able to see it in a 3D. Thank you.
Thank you, Dr. Raju. Now we have Dr. Chaitanya and Kim. And after Dr. Chaitanya, we have Professor Arvind Moria in other podium.
So today I'm talking on a smart OT device. So the main reason that I innovated this thing is because of the lack of staff. I'm an independent surgeon. Hi, my name is Dr. Chaitanya Aravindankam. Today I am here to talk on the topic of surgical synergy, where you have an OT assistant for being a smart AI assistant. The main problem with today's individual practitioners is your OT assistant might not be skilled, or you do not have enough OT assistants at the right moment. So I have programmed my entire OT with voice commands, as it will be much easier for surgeons to do with voice commands. So let me show you how the first voice command is designed into the OT. So let us see how everything comes to life with this one simple command.
Alexa, start theater.
Okay. So with just one voice command, you can switch on the lights, your microscope, your retro illumination, your TV and video recorder above that. Here I am simulating the surgical scenario, and here surgery, and to cut the glare from behind, so I use this command.
Alexa, turn off backlight. Okay.
This turns off the light that is causing any glare for me. So when you come to doing Rexis, I want to have retro illumination. So I will use this command.
Alexa, turn on retro illumination. Okay.
Now I want to record my video or live stream my video directly to YouTube. So I'll use this voice command.
Alexa, start recording. Okay. Alexa, stop recording. Okay.
Suppose you want some help from outside the OT, or you need to call.
Turn on bell. Okay.
While you are doing that, or your foot pedal switches fail.
Alexa, next mode. Okay. Alexa, next mode. Okay. Alexa, previous mode. Okay. Alexa, next mode. Okay. So, suppose you want to change some certain parameters in the factor machine while you're operating, you can do it with just a voice command. So you can say like, Alexa, increase bottle height. Okay. Alexa, decrease bottle height. Okay. You can even say like, Alexa, decrease power. Okay. You can say like, Alexa, decrease vacuum. Okay. Alexa, increase vacuum. Okay. Alexa, decrease aspiration. Okay. Alexa, increase aspiration. Alexa, change grade. Okay. Okay. Your machine.
Turn off all commands like this.
Alexa, stop theater. Okay.
Will it say, Alexa, complete the cataract surgery for me?
Maybe in future, sir.
Prevent a PCR from happening, and if PCR is happening, just stop the surgery, something like that. Interesting.
Yeah, and there may be some detrimental effects also we were discussing. It may misunderstand your command or the sound and
So one thing, the
with the mask maybe.
the voice commands, usually it takes your single command into multiple combinations, where it's very hard for it to, it's impossible for it to interpret into a wrong command. Either it doesn't do anything, or it just gives you the right command.
Yeah,
So apart
that
from
should
that,
be
it
foolproof to prevent other
and moreover,
adverse-
if you want it more foolproof, usually it takes a 2 weeks or 3 weeks time to adapt to your voice command. So the voice artificial intelligence are just now starting up. The ChatGPT one is much sophisticated and much faster, where you can run it offline also. It actually gives you a much control over the whole thing.
Yeah, looking at the way AI is intruding into all aspects, looks like this may come up in future. But the applicability, have you really performed a surgery with this?
Ma'am, like off the record, I do it on a regular basis, ma'am.
Oh,
like,
really?
Why? Because like the staff is a major issue when you have like 2 OTs simultaneously running on either side. So it will always be the senior surgeon who will have the most of the staff, trained staff. You'll be left out with ringing the bell or banging the doors for someone to come and help you. So this would actually help me to do most of the things apart from giving the lens in the last month.
But most of the things like this kind of machines, you can do it by yourself. You don't need actually the staff to tell you memory 1 to memory 2 and increase bottle height and all those things. A lot of things you can do on your foot pedal itself, right?
Bottle height and all, like even increasing vacuum and all is also a little difficult in all the machines. They need to have a dual linear kind of a foot pedal to do that kind of a thing. But this is like retrofit. You can, without voiding your brand warranty, you can fit it to anything.
Yeah, the cost of it?
Ma'am, it costs less than 20,000, including the whole video recorder, and it requires only a 4,000, 5,000 it's a broadlink thing. It requires a universal remote and then Alexa device which is readily available anywhere. The only factor is the surgeon should be more innovative on what he exactly wants the machine to work, for what commands he wants it.
No, so it means you have to first train that Alexa to means what kind of command, and so everything has to be preset. Then only it can be done.
Sir, yes, sir.
But there are many assistants, so you can't do without any assistant, because say handing over instruments, and suppose something in between you need. How can you say, Alexa, give me vitrectomy or give me the vitreous cutter? So those things means there are many things where you need assistance.
Definitely,
so, and
sir.
plus, as rightly pointed out earlier, that many machines have got most of these controls on foot switch, as well as some of the machines even has voice control. So those things are anyway is already existing.
Voice control, I don't think any phaco machine has today, sir.
No, means these things are not difficult, putting voice, because I think I remember there is one machine which has voice control. I don't remember right now, but there is one machine.
So well thought of and created this concept, very hard work. Just one question. What is the impact of having so much command on the patient? Patient is also listening what you're saying, telling to the Alexa. Because we want to have very silent kind of operation theater OR.
Sir, initially I thought the patient would be apprehended, he might complain and say, but then later on, coming from a tier 2 city, the patient, the feedback that I'm getting from the patients is like from their relatives, it's the most advanced OT in the city kind of a feedback you get. So it's a, I mean, I didn't expect that thing, but somehow.
And this Alexa help you in which step most?
Which
step was most helpful with Alexa?
Sir, mostly it will be between grade 1 and 2. There will be
so
a
shifting from grade 1 to 2.
Yeah, between those things where I want on the fly I want to go, or on that where I don't want to remove my probe out, or where I don't want to touch the remote or those things. So this will help you to fix those things. And recording and live streaming, definitely, sir. You can actually, without no one's intervention, you can directly live stream to YouTube.
Now quickly another story. I went to Seattle with a friend. He was working for Amazon. His entire bedroom house, everything was Alexa control. So he said, morning you get up, Dr. Rupesh, if you want to go to airport, just tell Alexa to do that. I was scared how do I switch on light, because there were no buttons in his room, entire house itself. Switch on light, switch on heater, open the door and all. I was like so confused that day. I was thinking whether I'll miss my flight and all. But I'm just telling you, that was the kind of thing, and first time I ever experienced living in an apartment with no button, no switches for any lights and electricity. And that was 3 years before when I went to Seattle.
Okay, thank you, Dr. Chaitanya. Now we have Professor Arvind Moria. And after Professor Arvind Moria, we have Dr. Jitendra Jethane. Are you here?
So good afternoon, respected judges and my dear friends. So I will be speaking on our innovation, that is the Pterigo scleral BCL. So that is pterygium gone forever. So it is a large soft scleral bandage contact lens. So there is no plasma blood, no stitch, no glue is required. So this is how it looks, the 21 millimeter diameter hydrogel scleral BCL, and we compare it with the other corneal BCL. This is how the size is different. And this is the packaging it comes, and the 75 is the hydration quotient, and it comes in the silver nanoion emulsion. So even if the viral load or the pseudomonas growth is in the millions colony forming unit, this silver nanoion, they reduces it to the lowest possible level. So this is how it is used after placing the limbal conjunctival autograft. This is how it is removed. So we require 4 hands for that. So the assistant needs to help us in placing over the graft and over the cornea and over the bare sclera also. So it's very simple, and we can maneuver it after placing this BCL also. This is the easy maneuverability option is always available to, like you can see in this video. So this is after 1 day. So this graft has already started healing, and this is after 7 days, almost healed. And so what are the advantages? So it covers all the 3 sides, and in case of double pterygium, it covers all the 4 sides, the donor area, the graft, as well as the corneal epithelial defect. And with more than 3,000 cases operated, there is no recurrence in a single case. And we are doing a head-to-head clinical trial also. And if we compare with the sutureless, glueless, as well as with the glue, so they have 5% of recurrence, but in this methodology, there is no recurrence seen. Very simple cut paste sort of thing, and hardly it takes 5 to 10 minutes of surgery. And these are the other 12 indications. Yeah. So the K-Pro patient, they are very happy after implantation of this. And even after the OSSN removal by the oncosurgeon, they are also getting good results because of the high hydration quotient. Thank you so very much. I'm happy to take any question. And it's no financial interest. Its cost is 1,500 rupees only.
So is there a universal size or multiple sizes?
Yes, it's customized also. In the patients of aphakia, it can be customized to spherical. Even toric versions are also customized. So yes, the ideal size is 21 millimeter, especially for the pterygium, because there are double pterygium. Especially I am working in down south, so we are getting a lot of, I think 40% of the patients, they are double pterygium. So it covers.
Are there any cases where it comes out after
no,
a blink
not a single
or
case.
after rubbing the eye?
No, it does not come out. No. Yeah. And the
You
patients are very happy, no foreign body sensation, and the healing is very rapid.
You said recurrence is less as compared to the
Zero,
other.
zero recurrence. Zero.
So what factors are doing that? Can you throw
so
some light on that?
Yeah, so we can only hypothesize because there is no, that it is covering the areas well. It is keeping the graft in place, and especially the postulated, the limbal stem cell where they need to be there, one of the postulation, it may be. So that is right there where we really want it to start functioning.
And when do you remove this? When do you
US FDA approval, we can keep it as long as 3 months, and in the pterygium cases, it's for 7 to 10 days.
And you said that you have done 3,000 or 3,000?
Yeah, that is around 93 surgeons all over India.
Oh, okay. So all combined. I thought it's so. How much pterygium you are doing? I was surprised. That's
No, sir. No, it's combined Indian. We are doing. The clinical trial is going on. So the initial results, the recurrence is 5% in the sutureless, glueless, as well as with the glue. But in this, there is not a single case till now any recurrence.
No, so what is the idea that you think is the path breaking in this, that which is made something, was just the extension of the scleral contact lens?
The idea is we are dealing with the three problems, right? We are removing the graft, the conjunctival limbal from place, and that the lot of surgeons, they are taking a suture, right, to cover that area. But in this, it is not required. And also there is no suture required, there is no glue required. The glue is costing, I think, between 7.5 thousand to 15,000. So we are also saving a lot of cost here. And the healing is very rapid. This is what we observed. Especially Dr. Santosh Vanavar is using, Varun is using in after K-Pro cases, the patients are very comfortable after the OSSN cases. So it works very well. And especially a lot of aphakic patient. So it is customized according to those patients. Even toric version is also there. So the indications are endless.
Just one thing I will say for most of the presentations and including yours, as you said, there are many factors which one of the judges asked, and you said, okay, there are many, but you haven't proven. So there is a say by Sir Arthur Conan Doyle, is I never guess. It's a capital mistake to theorize and put together your theory before one has data. You need, what one start doing is to twist the facts and theories instead of theories to suit facts. So I will suggest people to do a proper study, a randomized study before we come up with a lot of things, and before, because we start believing our experience and then we start saying that, and it can muddy the literature and it will not be the right science. If you really want to do science, it's a good idea to do a proper study to make sure that all the factors which is preventing recurrences or anything in the previous presentations also has been addressed. Just a take home point if you can take.
Yeah, the trial is going on, sir. The initial results I have shared.
And that too, also register the trial properly on clinicaltrials.gov. Do it in a very proper way.
Yeah.
This is where it can differentiate a regular study from something. So do it in a very standard way, a randomized control trial where you put in and make sure that things are there. There are a lot of CRIO who can help and work with them and then recruit the patients in the way so that the study just not get there, and but it goes to a certain different level, and then we can really change.
Thank you, sir. Point well taken. Thank you, sir.
Thank you, Dr. Maurya. And we have a last presenter today, Dr. Jitendra Jethande, please.
Thank you so much. And last presentation, I hope everybody is not tired enough. So I would, we have created an app, and I would be telling you more about it. So when we do ROP screening, often we understand that it is the only way you can predict whether you can prevent further blindness or not. And ROP nowadays has become one of the leading cause for suits against our fraternity, mainly because there are some mainly because record keeping is the key, whether baby was referred promptly or not, whether baby was actually seen or not, and what were the findings. So all these things come under EMR, but there is no there is no collective EMR which can keep the pediatric ophthalmologist, retina person, the neonatologist and parents in sync. So we understand that these people are the stakeholders in this, and so we created this app where when you enter the app, basically what happens is you get a screen where you differentiate between these three people who is working on what. So if you log in into through your own account, you can go inside and you can add your own neonatologist, and those neonatologists will add their patients, and they will come on your screen as seen patients, unseen patients, or follow-up patients, and new patients. There are various things that you can do with that particular one patient. You can put all the data, you can put the, because there will all be date of birth and everything is already there, you already know beforehand that this is the patient with these comorbidities and has been referred to us. So what you do is you do the examination either with a fundus camera or with an indirect ophthalmoscope, and then you put the consultation details. You can change the consultation details, zone 3, zone 2, stage 1, and you can upload the photographs. The next screen is obviously of the neonatologist. So here neonatologist has his own login password. Their staff can put up as to which patients are to be sent to the ROP specialist. So they will be adding the patients with all their details, and those patients which they add will come on your screen as new patients or as follow-up patients or as patients which were missed or were not dilated and are unseen patients already added. So this is what neonatologists will have. These neonatologists will be within your purview. So they also will be having a lot of info on ICP, ROP 3 and all those classifications. And the third part would be the third stakeholder, that is the parents. Now the parents will only be able to access their own files, their own data. The good thing is that you can counsel with once they have this particular app downloaded, you can use it as a counseling medium also. So it will have your own data, talks, your own material, apart from the fact that they can always access their own kids' details, follow-up details, what was advised. And so there is no miscommunication between what was said, what was done, and what actually came out at the end of the day. So this is just one of the screens you can put up into the local language also, and then you can show videos, your own videos, and this is the sheet. So what is new? I mean, what have we done which is not available? We have basically done a very simple thing. We have combined all the resources on a single platform. In my own practice, it was a daily issue because whenever I used to go for ROP screening, it was difficult for me to collaborate and understand who is sending which patient and what happened at the end of the day. So I cannot access the data. I have to physically go into the EMR to see who were the premature kids, and then I have to see who were referred from where. So this app helps my practice into the fact that I can get all the notification, follow-up dates, all the reports go to the stakeholders directly once I put it inside the app. So that's all regarding this particular app. Any questions we can take?
So very interesting, very good. Do you think this data can feed into the EMR so that you have an app, and then there is a hospital EMR, so that if it is linked up some way, then automatically the information from here can be fed into the source, so we can feed, because that will become very nice.
Very nice.
Then you don't have two separate things, because otherwise the information will be fragmented, and then eventually we will not know whether it was on the app or on the EMR. So if it can be integrated, so you can consider that. And what I like about your thing is the education of ROP, and a lot of people miss out on that part. But what you have integrated is a very important aspect, and different languages, so that it's become an education tool also for the parents.
True. Thank you. Thank you.
Users can use it simultaneously if the app is installed in multiple phones.
So right now I am using it for around 10 NICUs, and each neonatologist has around 5 or 6 people who are into their username password. So I mean, that is like capacity building effort which can be increased. But right now I am using it to make sure that if there are any if there is a problem in user interface, or there are any small wrinkles, they can be ironed out before we put it on actual use to other people.
So if you have completed the ROP screening and the retina has matured, so is it possible to delete the data of one neonate so that the new neonate can be enrolled into the app?
No, there is no need. You can always get the data back, because that is the whole purpose, that if the patient comes back, you actually have a data that he was. So what happens is that, because of less information, sometimes parents feel that this could have been missed during ROP examination. So we should always have some data that, we had seen the patient and vascularization was normal.
You want to retrieve it back?
Yes,
even
yes.
On,
that actually, one of the reasons was to have the data for a longer time.
Okay, thank you.
I think these apps make the life easy. Just one addition to that, have you put some kind of alert into that?
Yeah,
so that if the patient is missing, or say...
No, I mentioned there are notifications that if they don't come on follow-up, it will come on their screen also, as well as on my screen also. Not only that, if they have kept 6 patients for me and pupil was not dilated in some of the patient, that will remain in unseen patient, and that will keep popping up till I don't put it in seen patient. So that actually another reason was that it had happened once that one of the child was missed out because staff felt that all the patients have been, the ROP screening was done. And so one of the patient was actually missed out. And then later on, there was some elevation, and then we felt that this baby was actually referred before, but could not come. So yes, notifications are definitely a part of it, sir.
And second part is regarding the securities of those data.
Firewall is there between the user interface of parents, doctors, and myself. I mean, we cannot go inside each other's this thing.
Thank you.
Just one more suggestion will be from my end. Now that the natural language processing and the chat GPT things are coming, so what you can do is using some of the LLMs, and there are some techniques to curate the published literature. You can use it, integrate, and put in a Q&A there, and where people ask, and it comes from the real evidence rather than the Google source or the common chat GPT, which can give a lot of incorrect information. So that can be something. Some people want to see some information about any major ROP study done, which are the things, so that it comes up from the evidence based rather than, so that something can be an improvisation on that.
That's wonderful.
And seeing that the firewall, sometimes it can be a tricky thing. What you need to do is to come up with a way to encrypt the data so that you don't include the patient identifier, keep it into that, try to use some form of blockchain.
True.
And so that you have that patient confidential information separately, come up with the ID, so that even if some hack happens into that, it does not.
Only the ID can be
only
seen.
the ID
True.
goes, and that too, there is no use, but it comes with the patient information, then that will allow you to. So few things you can take it forward.
Definitely.
But good thing is that you focused on one topic, dive deeper into that, and then you came up with this thing. So just that. So that way, AMD community, diabetic retinopathy community can come up with one app which can definitely make our life easier.
Easy. Thank you. Thank you. Thank you so much.
Thank you very much, Professor Jethani. So with this, we have come to the end of this session. On behalf of AIOS ARC, I am extremely thankful to all the judges, to all the participants, and to all the delegates for being with us today in this very interesting session on innovation and novelty, where basically we are checking the innovation which will ultimately impact the society. So thank you very much. Sir, yes, the mementos and things, certificates.
Evidence. AI करने वाला बस सर तो बैठो सारे नहीं कौन ले गया नहीं कोई नहीं लेकर गया